Hello, in this slide presentation, we will discuss drugs for hypertension. So what are the classifications of diuretics? There are four major categories. The loop diuretics, which include furosemide, thiazide diuretics, which include hydrochlorothiazide, osmotic diuretics, which are mannitol, which we won't discuss here because that's hospital-based. Potassium sparing, and there are two subcategories there. You have your aldosterone antagonists, such as spironolactone, your non-aldosterone antagonists, which would be triamterene, and there's actually a fifth category of the carbonic anhydrase inhibitors. So first, the loop diuretics. The major one here is furosemide or Lasix, the trade name. It is the most frequently prescribed diuretic. What's the mechanism of action? It acts on the ascending loop of Him to block reabsorption of that sodium and chloride. What are the pharmacokinetics? There's a rapid onset. If they take a pill, it takes 60 minutes. With IV, it takes 5 minutes. So you can see why if a patient comes in and fluid overload, that giving them IV Lasix would be very helpful. The therapeutic uses: pulmonary edema, edematous states, and hypertension. So what are the adverse effects? You're going to have the hyponatremia, the hypochloremia, the dehydration, as I talked about earlier. There can be hypotension from that dehydration with the loss of volume, and there's relaxation of the venous smooth muscles. You can have hypokalemia, which is a problem with the Lasix products and the thiazides, in that they, besides losing the sodium and chloride, you also lose the potassium. So it's very important to monitor your patients and teach them about that. You can also have ototoxicity. There can also be hyperglycemia, so you'd have to be careful with patients that are diabetic or have uncontrolled diabetes. You can have hyperuricemia. You can you have to be careful in pregnancy, and there's an impact on lipids, on calcium, and magnesium. So you can see there are a lot of electrolyte and mineral issues with using a diuretic that you have to carefully monitor as a provider of these meds. It's not just monitoring as you did getting labs and reporting them to someone else. You will be responsible for making sure that the patient's electrolytes stay at levels that are safe, and if your patient is a diabetic, to carefully monitor for that also. What are some of the drug interactions that you have to watch for? If your patient is on DIG or will need DIG, if they're on any other ototoxic drugs, if they're on any potassium sparing diuretics in addition to Lasix, if they're on lithium, because lithium is a salt-based drug, and if you're also on Lasix, you could potentially the patient could become potentially toxic. Other antihypertensive drugs, because you already have issues with potential hypotension. So you want to make sure that, especially with your elderly patients, that you're not going to put them in a situation where they might have falls, which can be very detrimental, if not sometimes deadly for them. And you want to watch out with concurrent use of any NSAIDs while you're on Lasix. One of the reasons for that is that they also they can cause fluid retention. So that's counteracting what you're trying to do with the diuretic. What are the preparations? You have oral preparations, as mentioned earlier, which take about an hour to take effect. And then you have your IV preparations, which can take 5 minutes to take effect. Next, we have the thiazides, also known as benzothiodiazides. Their action is very similar to those of loop diuretics. They increase the renal excretion of sodium, chloride, potassium, and water, and also can elevate the uric acid and glucose levels. So, again, you have to be careful with your patients with diabetes, um, your patients that are prone to dehydration, especially your elderly patients, patients that have gout, you have to be careful with. The maximum diuresis is considerably lower than with the loop diuretics, such as with the hydrochlorothiazide, which is the most widely used, it works in the distal convoluted tubules. It peaks in 4 to 6 hours, and it's generally used for essential hypertension, for edema, not severe edema. Again, you'd want to use Lasix, and in diabetes insipidus. What are the adverse effects? You can again have the hyponatremia, the decreased chloride, the dehydration, the hypokalemia. Um, can't use it in pregnancy and lactation. It can cause the hypoglycemia, of course, the increased uric acid, and it can also impact the lipids, the calcium, and the magnesium, which is the same as the loop diuretics. Drug interactions, also similar with the DIG, with other antihypertensive medications. Usually, if you use it as an augmentation, just be careful that the patient's pressure doesn't drop too low. Again, because we worry about falls in the elderly. Can it reduce the renal excretion of lithium just like the loops? So you don't want to have the toxicity because with lithium, of course, you have that narrow therapeutic index, which you have to worry about. The NSAIDs can blunt the diuretic effect because, again, I said that they can cause fluid retention. So you're kind of counteracting the effect you want from the hydrochlorothiazide. And but one thing, it can be combined with ototoxic agents without that increased risk of hearing loss, which you would get with the loop diuretics. Next, we have the potassium-sparing diuretics. They only give modest increase in urine production, so if you have a patient that has a lot of issues with fluid retention or needs a more powerful diuresis, then this would not be the one you would consider. But there is substantial decrease in potassium excretion. So if that's important with your patient because they're losing too much potassium with the other two, you will have to consider using this one. Another reason to consider is with the other two, the loop and the thiazides, you can have some uh, cross sensitivity with a sulfa allergy. And of course, it would depend on the severity of that sulfa allergy, but you may need to consider putting the patient on a potassium sparing diuretic if that is the case. Usually, though, because of only modest increases in the urine production, you usually aren't going to use this diuretic alone. you will be considering using another antihypertensive agent. And then, of course, you have the aldosterone um, antagonist and the non-aldosterone antagonist. One thing I think that's interesting with the spironolactone is that it is used with birth control Yaz or Yasmin um, during the days of the hormone free when you have the breakthrough bleed, and that is to help with the diuresis, the fluid retention that women get with their during the menstrual cycle or during the premenstrual cycle. So when do we use it? We use it with hypertension, with edematous states, say with CHF, with heart failure, um, when there's primary hyperaldosteronism, with PMS, like I said, to help relieve the fluid retention, with polycystic ovary syndrome, and acne with young women, it also helps. Adverse effects, then of course you can have hyperkalemia because it helps retain potassium. You can have benign and malignant tumors, and you can have endocrine effects because of its effect there and with the hormonal issues. Drug interactions, you have to watch with the thiazide and the loop diuretics, of course, because you are that's trying to get rid of the potassium, and this is trying to spare it, so you're working against each other, and you'd have a larger loss of sodium, which could be a problem with the water and increase the um, potential for dehydration. And also any other agents that raise potassium levels, because of course we know that elevated potassium levels can be harmful from a cardiac standpoint. The triamterene disrupts the sodium-potassium exchange in the distal nephrons. It is a direct inhibitor of the exchange mechanism. It decreases sodium reuptake and inhibits ion transport. It's mainly used, of course, for hypertension and any edema. So what are adverse effects? You can have hyperkalemia, you can have leg cramps, which you can also get with the other two. You have nausea, vomiting, dizziness, and rare blood dyscrasias. Now we're going to move from the diuretics to the ACE inhibitors. And their mechanism of action is to reduce the levels of angiotensin II and increase the levels of bradykinin. So the therapeutic uses of ACE inhibitors includes hypertension, heart failure, MIs, diabetic and non-diabetic nephropathies, and the prevention of MIs, strokes, and death in patients at high cardiovascular risk. What are the adverse effects? You're going to have first dose hypertension, which is what it says is that with that first dose, the patient's blood pressure may drop. So you need to warn the patient when they first start taking this for the first few days. They want to make sure that they get up slowly so that they don't have that orthostatic hypotension. If they're taking another diuretic, another agent, you might have them hold off on that if you're worried about hypotension, and have them wait a couple of days before they take both of them together so that they can avoid that. There's definite fetal injury, so you don't want to give it, especially in the second, third trimesters with the baby. A cough is an adverse side effect, and that's probably one of the biggest ones why people stop taking an ACE inhibitor, and it is caused by the increase in the bradykinins. You can have angioedema, which can be potentially life-threatening. So if the patient reports that at all, emergency care should be sought, and they never take them again. I personally had the angioedema. I had taken uh, lisinopril for 3 days at a very low dose, 5 milligrams. Woke up that third morning, lips swollen, knew I had to go to the ER, went to the ER. Was not nobody was worried at that point. I had IV meds to reverse it, finished the IV, went to the restroom before I left. My face just blew up. I was immediately put on the urgent side of the ER. Um, I was getting that look like you may not make it out of here, in the hospital for 4 days. Swelling overall didn't subside for over another week. So I definitely will never take an ACE or an ARB. Um, Again, listen, I don't want to wake up, because they even told me that if I had taken 10 milligrams, which is usually more of the starter dose, I just personally had started with 5, that I probably would have died in my sleep. So it is a very real and very scary adverse effect of taking an ACE inhibitor. You can also have hyperkalemia. So certainly if the patient is on a spironolactone um, or one of the other potassium-sparing diuretics, you have to be careful. Another effect could be renal failure or neutropenia. Drug interactions, of course, we just talked about other diuretics with other hypertensive agents, so you don't drop the blood pressure too much. Drugs that raise potassium levels, again with the lithium, so that you don't have toxicity there, and with your non-steroidals, because of course they cause the fluid retention. So then we move on to our ARBs. For the ARBs, they block the access of the angiotensin II. The difference here, the ACEs actually block the production from 1 to 2, and this blocks the access of 2. It causes dilation of the arterioles in the veins. It prevents angiotensin II from inducing pathological changes in the cardiac structure. It reduces excretion of potassium, decreases release of aldosterone, which is involved in that potassium. It increases the renal excretion of sodium and water, does not inhibit kinase 2, and does not increase levels of bradykinin. So therapeutic uses are similar to those of the ACE inhibitors for hypertension, heart failure, diabetic nephropathy. You want to give it if a patient cannot tolerate an ACE inhibitor, because it still gives the same protection from MI and stroke. In high-risk patients, may prevent development of the diabetic retinopathy, and if the patient is normotensive diabetic, it's not shown to help with the prevention of nephropathy, as what was thought when those years ago, is that if you had a diabetic patient, put them on an ACE or an ARB for that prevention protection. But now we see that if they don't have high blood pressure in conjunction with their diabetes, that is not warranted anymore. Adverse effects, again with the ARB, you can have the angioedema. So if the patient has had a reaction like I did to the ACE, you would not put the patient on an ARB. Same issue with fetal harm, the renal failure, and the ARB, since it does not produce accumulation of the bradykinins, you have a lower incidence of a cough. So it doesn't mean that there may not be a cough, but a much lower incident of a cough. So if a patient didn't have any other adverse effects or issues with taking an ACE inhibitor, but the cough was too much for them, then you could suggest switching to an ARB to see if the cough would lessen, so that they could still get all the benefits of the ARB. Then you have your direct renin inhibitors. Tecturna is the trade name, and it binds tightly with renin and inhibits the cleavage of angiotensin to angiotensin 1. So this one works even farther back. So you have this one that prevents conversion to an angiotensin 1, your ACE inhibitor from 1 to 2, and then the ARB from blocking the 2. Side effects, again, you would have the angioedema, the cough, the GI effects, hyperkalemia, the fetal injury, and death. Hydralazine. For drugs for hypertensive disorders of pregnancy, if there's chronic hypertension in the pregnancy, ACE, ARBs, or the direct renin inhibitors are contraindicated. So if the woman becomes pregnant, she needs to be switched to another hypertensive agent, because most of the others can be used, and a lot of times it's considered a risk benefit. For preeclampsia and full-blown eclampsia, you want to use the hydralazine, or when they have to, they'll use